Good morning, everyone. Again, it's such a wonderful pleasure to be at another family meeting. And today I'm going to talk about a subject that I actually spoke about at the South African FOP meeting. And it's on the do's and don'ts of FOP. And so for some of you, this will be a review. For some of you, this will be new. But for everyone, I think the key messages will be important, and I think it's important to reinforce these messages. So let's start with flare-ups. In early life, flare-ups are going to be in the head and neck region. As individuals with FOP get older, usually we see them in the back and torso, and then later, as the disease progresses, in the arms and legs. And so, in a survey we did involving 500 patients with FOP, we really began to understand when flare-ups occur. Most flare-ups occur as a result of injury, viral infection, or overuse. We also see flare-ups as a result of intramuscular injections, and many flare-ups are the result of unknown causes, and so they're spontaneous in about 60% of individuals. And so it's important when you have signs and symptoms of a flare-up, mostly swelling and pain, that you contact your physician. But there's also some things that we'll talk about that you can do even ahead of time before you make contact with your physician. And in general, depending on location and circumstance, we'll recommend one of two classes of drugs for symptomatic relief. One class are the NSAIDs, or nonsteroidal anti-inflammatory agents, and we usually use these when a flare-up is present in the back or chest. In other areas, we tend to use steroids like prednisone, and after severe traumas, we tend to use prednisone as well. If the flare-up is in the anterior neck, in the throat area, this is a medical emergency. This is a submandibular flare-up. You need to seek medical attention quickly, especially with the first signs of trouble swallowing or breathing. We tend not to want to manipulate the jaw. We need to monitor breathing, and by and large, we use higher doses of steroids for longer periods of time. This is another point I want to make. Even though we always want you to contact your physician when you think you're having symptoms of a flare-up, it's also important to start steroids early and then contact your physician. And so this is the so-called pill and pocket approach. And so it's important for you to have a supply of prednisone on hand no matter where you go, at home, at school, in case of emergency, when you travel, etc. Limb swelling. Limb swelling is a problem that we see fairly often, especially after flare-ups of the lower limbs. Swelling can be chronic, lasting for months to more than a year. There aren't a lot of things we can do about this. We often recommend elevating the legs while sleeping. It's important for your doctor to rule out a possible blood clot. Sometimes if we're concerned about the possibility of a blood clot, we'll use medicines called antiplatelet medicines like aspirin. Sometimes we recommend fitted support stockings, but by and large, the most success that we have from experience is to use lymphedema therapy, and we get this at certified lymphedema clinics. What about activities? We certainly encourage activities for everyone, all ages, but let's be clear, especially with occupational and physical therapy, it's passive range of motion that we do not, or that we warn against. So in other words, we don't want someone else to manipulate your joints. Active range of motion is absolutely fine. And other activities like, especially non-contact activities, including activities in water, are fine. Injuries. So on the left there, you can see a list of known causes of flare-ups. So some of these seem pretty common sense, and they include injections and immunizations into the muscle, biopsies, of course, removal of heterotopic bone, elective surgical procedures when we can avoid them. We can't really avoid viral illnesses, but we can, later I'll talk a little bit about preventative measures, contact sports, muscle trauma, and muscle fatigue and stretching. So there are things that we can do to prevent injuries. We can't obviously avoid all injuries. Falls. So the biggest concern about falls is really when the shoulders and the elbows are locked and we can't brace our fall the way we would normally brace our fall. And the reason why this is potentially life-threatening is because we hit our heads if we can't brace our fall. And so there's the possibility of brain hematomas, which is a surgical emergency. So I think we have to be careful in deciding, when protective headgear is appropriate, especially in children who have upper limb involvement. And again, all head and neck injuries should be evaluated immediately. Immunizations. Ed talked a little bit about this, but there's really some excellent guidance in the ICC management guidelines. Basically, subcutaneous injections are fine, avoiding vaccines given into the muscle and those into the nose with live or weakened viruses. I'll talk about COVID in a second, which, as Ed pointed out, might be an exception to that rule. Do not give vaccines during flare-ups, and one should wait 6 to 8 weeks after a flare-up resolves before getting any vaccinations. And then, importantly, and this is the preventative point, all contacts should be immunized against pertussis, influenza, and COVID-19. So I think that even in the absence of getting vaccination for personal or medical reasons, I think a lot can be done from the preventative point of view. So the decision to take the COVID-19 vaccine is a personal one, again, based on the balance of risks and benefits. Ed shared earlier that out of 23 patients who received the COVID-19 vaccination, as indicated, in other words, into muscle, of those 23 patients, none subsequently had a flare-up. Now, 23, you might say 23 is a small number, but that's the information we have. And so, again, it's a decision that should be discussed with your medical team. But again, importantly, if you're going to get the COVID-19 vaccination, it should be administered in the same route in which it was approved. And then again, I'll remind everyone that masking still continues to be an important component of controlling the spread of COVID. IVs. So blood collection and IVs are okay by superficial access into veins. Should be done by an experienced phlebotomist. However, the tourniquet time should be limited. A related point is blood pressure measurements. Again, the pressure to which the cuff is insufflated, and the duration of the insufflation should be limited. This is an important point that we bring up almost every family meeting, almost every Ask a Doctor session, and that is heart and lung health, and these are really intimately related. The diaphragm is spared in FOP, and what that means is that it can be exercised just like any other muscle, and it can have great benefits. And so I think Michelle yesterday told everybody that there would be a spirometer in your bags. Please use them. If you don't want to use a spirometer, there are other activities, including deep breathing, swimming or hydrotherapy, singing. But I think using a spirometer gives you some feedback in terms of how well you're improving in terms of lung volumes. And remember, the late consequences of FOP, many of them are all related to this restricted lung function that occurs for many different reasons, not the least of which is heterotopic ossification, which limits the expansion of the chest and worsening scoliosis. Hearing loss, very common in FOP. Screening should begin in childhood, and hearing aids may also improve the hearing loss, so there's an intervention here. We always would say that about 50% of patients with FOP suffered some sort of hearing loss. I mentioned earlier that we had a meeting in South Africa a few weeks ago, and where we had a hearing assessment clinic, and 100% of everyone who was assessed had some type of hearing loss. So it's possible that the prevalence of hearing loss is actually much greater than we think. And so if assessments haven't been done or normal at younger ages, there may be some benefit in continuing to monitor hearing loss. Kidney stones. Patients with FOP are 3 times greater risk of kidney stones. It's unclear if it's related to the ACVR1 mutation or related to immobility and perhaps some reluctance to or inability to frequently go to the bathroom if one drinks a lot. But nevertheless, the treatment works. It's encouraging adequate fluid intake, preferably water. There are studies, large studies, which show that drinking 1.5 liters to 2 liters a day is enough to substantially prevent or reduce the incidence of kidney stones in the general population. The other things that contribute to kidney stone formation are high protein intake and high salt diets. And the last point is also important. There's this misperception that avoiding calcium in the diet will reduce the likelihood of kidney stones. It's actually not true. It's important and in fact, the opposite is true, that doing that, trying to avoid calcium in the diet, actually increases the risk of kidney stones, paradoxically. So adequate amount of calcium in the diet based on age and sex, and then these preventative measures. Anesthesia. General anesthesia is a very important consideration for certain procedures. It should not be lightly dismissed because of the ankylosis or the locking of the cervical spine, because of patients having locked jaws. General anesthesia cannot be given in the way that it normally is. It has to be done through a special type of anesthesia where it's delivered through the nose and into the lungs. Always, always, always seek expert anesthesia advice from an FOP expert. Michelle mentioned last night Zvi Grunwald, who's the world's expert on anesthesia in FOP. He has his cell phone on all the time. He will always get back to consulting anesthesiologists anywhere in the world. So no procedure requiring general anesthesia should be done without consultation. And I think this is my last slide. We have ask a dentist here, and I would encourage everybody to seek out their advice. But in general, preventative dental care should begin at an early age, avoiding sugary sweets and drinks, avoiding mandibular blocks. This is a type of local anesthesia that dentists sometimes use. Avoid overstretching of the jaw and muscle fatigue, and then finally consulting dental experts who are familiar with FOP before any procedures. So again, this was a very high-level overview of do's and don'ts in FOP. Some of you know this information, others of you may not, but again, trying to reinforce these very important aspects of FOP care. Thank you very much.
Thank you, Dr. Pignolo. Yeah, we have lots of new families here this year, but I think that was an important reminder for all of our families. So I am excited to bring up our next speaker, and I wanted to say that Michelle mentioned last night we have several families joining us from Latin America and Mexico here this weekend, and this next speaker is to thank for that. So Dr. Hidalgo-Bravo is a geneticist at the National Institute of Rehabilitation in Mexico. He is the principal investigator of the IPSIN, Insight, and Regeneron clinical trials and was recently appointed as a member of the International Clinical Council on FOP. So Dr. Hidalgo is going to talk to you about a quality of life study in patients with FOP in Mexico.
Good morning, everyone. Thanks, Hope. It's an honor to be here with you. This is my first time as a speaker here in the gathering. Actually, it's my second time here in the event. So for me, it's really, really an honor to be here. Okay, I work in Mexico, as Hope said. We have identified like 30 families in Mexico with the FOP. Most of them took like 7 years to get a diagnosis. Well, you will see. And now we conducted a survey trying to understand and get a better knowledge about the daily life of the patients we are treating, so we can design strategies for helping them and do our best to take care of them. So we get answers from 19 patients. So this is the sex distribution of the patients. And then this is the age of the patients that we interview. So as you can see, most of them are in the 4th decade of life. So that's a good thing because you know all the restrictions and the complications that the patient can have. And this is what I want to show you, the age of diagnosis. So as you can see, in the first years of life, we have most of them. In Mexico, we have 3 family cases of FOP, which is very unusual. So for us, that was helpful to know that one of the parents had FOP, so we can keep close survey to them when they were pregnant. So that was complicated pregnancies. And then, as you may know, most of them underwent a surgery, and this is what we try to do to avoid surgeries. So now we are trying to do like some kind of screening, newborn screening, basically with the toes. so to avoid the surgeries. But as you can see, the number of surgeries is very common in the patients that we interview. So then we move to try to understand how's the daily life of patients. So most of them don't go outside their homes. So we try to see where is the place at home for more risk for them. So as you can see, the bathroom seems to be the place where the accidents happen. So what I want to do, or want you to do, is to share your experience. Because when we talk to the patients, we notice that they do some strategies at home to avoid the accidents. And when we introduce one patient to another, they start to share what they do to avoid all the accidents. So that's what we are trying to do. Get a community, and then they can share their knowledge about how to prevent these accidents and where to prevent it. As well, most of them and most of you have done some home adaptations. And then also, because it's not always easy to get materials for the adaptations or the appropriate materials, so they can do the adaptation with the materials they have at home. So this is important for us, because then we can give advice to them, and then try to prevent these accidents. And as you heard before, these accidents is the principal trigger for the flare-ups. But as you can see, most of the patients haven't done any adaptation at home. And then, how they cope with all these difficulties. So what's the main network for support? Most of them rely on family and friends. But for some of them, because when they grow up, family probably is not very close, and they start relying to medical staff, to another patients or associations. So this is what we want to learn as well, how we can try to get them a better protection, a better network of support. How can we do, or what can we do to give them this support? And this is a survey about quality of life that is a validated instrument. So there are 36 questions in this survey. And it's interesting to see at the end how they consider the health and their quality of life. As you can see, most of them consider the quality of life as good. So this is interesting, because beside all the problems that they can have at home or going outside home, they still consider they have a good quality of life. This is about some duties that they have to do on daily basis, and how they consider FOP can limit the performance of these duties. So as you can see, most of them, they consider that the FOP is limiting a lot these activities, which is daily life activities. And then this is the questions about the last 4 weeks, if you have some emotional problems, and also with normal activities, which includes family activities, friends activities, or another kind of group activities. So as well, they feel that they are extremely limited about these activities, and they have serious impact about their emotional life. As well, the physical health, how is your physical health, or how they consider their physical health in the last 4 weeks. So as well, most of the time they feel FOP is interfering with the quality of their physical health. So this is interesting, because then we try to move and propose some activities for them. Most of the patients ask about the activities they can do. As Dr. Pignolo said, they can do some activities to prevent the stiffness of the joints, and also to preserve the pulmonary function. So what we learned about after this survey is that the thing is, one of the first things is to shorten the time for diagnosis. This seemed very simple with the screening of the first dose. Unfortunately, in Mexico, we cannot make this happen yet, but we are working on that. Our group is trying to get this done. And also to prevent surgical or invasive procedures, which are not necessary sometimes. Sometimes because other physicians, they don't know what can do and what cannot do. Sometimes they underwent surgical procedures that were not necessary. So we try to extend this knowledge to other physicians who are in contact with the patients, and then to consult us before they decide to do a surgery or something like that, or another kind of procedure. And as well, this is very important for their daily activities, is to be able to do some home adaptations. This is complicated, we know, because in Mexico we have some families that they live in very small places where it's difficult to make these home adaptations, or it's difficult to move to a hospital if they need it. So we are trying to keep them in touch by phone call or by any other mean, so we can give them this support. And we hope that this information can help us to give them a better care and to design new strategies for care them. And also, I hope that you can start sharing your experiences. I know that here in the States and in Mexico, there are a lot of differences, but I'm sure that at least you can share your experience and get something better from them. And thank you all.
Thank you, Dr. Hidalgo-Bravo, for that encouraging message of really continuing the theme we've been discussing throughout the day. So our final speaker is joining us virtually, and then after Dr. Al-Mukaddam presents, we're going to have all of the FOP experts join us up on stage. Dr. Al-Mukaddam will join us, and Dr. Kaplan will join us for Q&A from the audience. So get your questions ready. Dr. Mona Al-Mukaddam is an adult endocrinologist in the Division of Endocrinology, Diabetes and Metabolism at the Pennsylvania Penn Bone Center. Dr. Al-Mukaddam is a board-certified internal medicine and endocrinology, diabetes, and metabolism. She's the principal investigator on ongoing clinical trials in FOP at the Center for Research in FOP and Related Disorders at Penn, and is a member of the International Clinical Council on FOP. She's going to be doing a presentation today on bone health and FOP, and I'll hand it over to you, Mona.
Great, thank you. Can you hear me? Okay. How am I supposed to know if you guys can hear me or not? All right, I think I can hear some laughter, so I'm assuming you guys can hear me. Okay, so as Hope mentioned, I'm Mona Al-Mukaddam, and I work at University of Pennsylvania with Fred Kaplan. I'm an adult endocrinologist with, special interest in bone diseases, so I do manage a lot of patients with common diseases like osteoporosis, but as well as FOP. Can we move to the next slide? All right, so I would really like to thank Ed Chow for his lovely introduction, because I really think it set the stage for my talk today. I didn't know what he was going to discuss, but I was very happy to see that his first paper was about fractures and the ability to treat them non-operatively. But really that kind of highlight, and then also the talk about palovarotene and some of the concerns regarding bone mineral density. So historically, we've always been focused on the extra bone formation, but today I want to talk about the bone health of the normotopic bone, so about the bone that is in the correct location. Next slide. So, Ed mentioned the term osteoporosis, and osteoporosis, it is a very common disease, and so you might already be aware of this term. but I just wanted to go over what is the definition of osteoporosis. So if you look at the words, osteo is bone and porosis means pores. So it means porous bone. And that bone is not only low in density, so you have poor bone density, but it's also bone that is weak, and the quality of that bone is not very good. And when you have those two changes, that bone becomes at increased risk of breaking or having a fracture. So based on my left side, so if you look at the figure on the left side, this is an image of a vertebra that does not have osteoporosis. The bone density is good, and the quality of this bone is good, and this bone is less likely to break. But if you look at the vertebra on the right side, that's of a patient who has severe osteoporosis. So you can see that the bone is less dense, but also this bone has holes in it, and this bone is more likely to break. Next slide. So what are the symptoms of osteoporosis? How do we know if we have osteoporosis or not? Well, unfortunately, we don't know. So it is a silent disease. It doesn't cause any pain. It doesn't cause any discomfort. The only time that it might cause symptoms is if someone has a fracture. So when someone breaks a bone, they're going to have pain from that fracture, and then they might have symptoms that way. It is a major public health problem. So over 50 million Americans have low bone mineral density or osteoporosis, and it's associated with 2 million osteoporosis-related fractures annually. And these fractures are associated with significant mortality and morbidity, including pain, loss of independence, and respiratory and gastrointestinal issues. And that's associated with significant health-related costs. Even in our general population, osteoporosis continues to be underdiagnosed and undertreated. Next slide. So what about FOP? We've known for a very long time that people living with FOP are at increased risk of breaking bones. In this image, I just wanted to highlight this image. This is the skeleton of Carol at the Mutter Museum. And I don't know if it's displaying well for you guys, but I think what was really impressive with Carol's skeleton is not only the deformities and the extra bone formation, but was how her normal bone, the normotopic bone, is almost transparent. It was so low in density. So I don't know if you can look at the shoulder area and look at the clavicle area here on the right side on the top, but that bone is almost transparent. And so the reason why we, suspected and we knew that our patients will have osteoporosis is because, and their increased risk of breaking bone is because they fall a lot. And when they do fall, they can't use their hands to support themselves if their shoulders are fused and if their elbows are fused. And so, if I were to trip, I might just extend my hand and hold on to a rail and prevent myself from completely falling. But people living with FOP might not have that ability to prevent a bad fall from happening. We also know that vitamin D deficiency is very common. We do believe that, because of staying indoors and not being exposed to the sun a lot, as well as nutritional deficiencies in vitamin D. And as Bob Pignolo just mentioned, kidney stones are very common in FOP patients. And we think that, with kidney stones, there's some calcium loss in the kidneys that is associated with osteoporosis. We also know that in our patients who are very inactive, even in astronauts that go out to space and, they don't have any gravity and they're floating around, that is associated with bone loss and osteoporosis. Also hypogonadism, so low estrogen in our females and low testosterone in our males, also contributes to osteoporosis. And then the medications that we give. Most of our patients have received prednisone at some point during their FOP journey, and we do recommend prednisone almost as standard of care for major flare-ups. And prednisone is known to have very bad effects on bone quality and increased risk of fractures, bone loss, as well as muscle weakness. Next slide. So in the general population, and I think Ed Chow alluded to that, we usually do something called DEXA scan, which is an X-ray based technique to measure the bone density. It's a non-invasive, pretty easy technique to do. It has very low dose of radiation exposure. And if you can see in the figure on the right, that's a table, that's a DEXA table where patients would have to lay on that table and X-ray images would be obtained of their spine and their hip to measure the bone density. Now, DEXA scans have a lot of limitations. One is they look at aerial bone mineral density, meaning that we're looking at the spine and the hip as a two-dimensional structure when we recognize that it's actually a three-dimensional structure. So next slide. So the problem with the FOP is that DEXA scans are useless because, as you can see in this patient on figure A, where they had a DEXA scan, and you can look at these DEXA images, well, if a patient can't move their arm, the overlaying hand will be in this field of vision. And so now you're measuring the density in the hand as well as in the hip, and we don't have any normative data for that. And then in the spine, usually in order for us to interpret the density in the spine, we usually need the spine to be straight. You don't want to have any bone in front of it or behind it, or any other artifacts that could affect the analysis of the bone density inside the spine. So for that reason, we never do DEXA scans on our FOP patients because we know the results are going to be completely unreliable. And so we haven't been able to evaluate the bone density in FOP patients for a very long time. Next slide. So there's a relatively recent technology that also Ed Chow briefly alluded to, which is the BCT, which is developed by Tony Keaveney out in California. And that was really developed to look at CT images so you can measure the volumetric bone density and strength. And this was really designed to utilize CT scans done for other reasons. So if patients were coming in for abdominal pain and they got an abdominal CT scan, you can then use the CT images of the spine in the lumbar area to analyze the bone density inside the vertebra. So you can easily, if you look at the figure on the right, the last one with the yellow circle, or the yellow oval, you can specify that you want to analyze the bone density in this specific location. So you're able to exclude the heterotopic bone from that analysis. That technique was developed using high resolution imaging. So the CT scans that are done clinically for evaluation of abdominal pain have very high resolution. Next slide. But what we were able to do is utilize the CT scan images that were done in the clinical trials to evaluate volumetric bone mineral density in FOP patients. So a couple of things. This is the first time this is ever done in FOP patients. This is the first time that this technique has been used on low resolution imaging. So the whole body CT scan that's done in these clinical trials were intentionally low resolution in order to minimize the amount of radiation our patients are exposed to. So we don't know how well this analysis is while utilizing these low resolution imaging techniques. The other thing is, as you know, our patients have a lot of FOP patients have significant curvature in their spine or what we call scoliosis, and we don't know how that could potentially affect the validity of these results. But at least now, this is for the first time, we're able to comment about the bone density and the bone quality in FOP. And so I'm going to be reviewing some of the data from the natural history study. So those are people with FOP that did not receive any intervention. And I will also go over the MOVE study, which is the phase 3 interventional study where patients were given palovarotene. But at baseline, as expected, most of our patients had low volumetric vertebral bone mineral density, and they had low bone strength. And at baseline, so that's even without palovarotene, 20 to 25% had evidence of vertebral deformities, or what we call spinal fractures. So this is really at baseline. There was a very high prevalence of low bone mineral density and fractures. So if we look at the table, the second row, you can see that about 7 to 12% of patients had more moderate or severe fractures, and that's again at baseline. But after 12 months of palovarotene treatment, 28% had new onset fractures or new onset vertebral deformities over those 12 months, versus in the natural history study where patients did not receive palovarotene, only 11 had new onset vertebral fractures. What I don't show here is that there was also a reported decline in the volumetric bone mineral density measurements that I think Ed Chow did report in his presentation. But overall, this does seem to suggest that palovarotene can decrease bone mineral density and could potentially be associated with vertebral deformities. I do have to say I was involved in these clinical trials, and we did not have any clinical fractures in the spine that we saw. So those were all what we call imaging-based fractures, so radiographic evidence of fractures, but not clinically evident fractures. Next slide. So what should we do right now, right? I'm going over all of this, terminologies and data and numbers and things like that. I think we all appreciated that people living with FOP are at increased risk of breaking their bones. We do know that steroids have a negative effect, and now potentially palovarotene as well. But that doesn't mean that we tell our patients not to take the steroids, and it doesn't mean that we tell our patients not to take palovarotene. And so there are certain things that we can change and certain things that we cannot change. So having FOP, we can't change that right now. Needing to take medications for FOP, we can't change that right now. But let's focus on things that we can change. So let's talk about modifying some of the risk factors. So other things that could affect bone quality, like smoking, excessive alcohol intake, excessive caffeine intake, or excessive soda intake. So those are things that we kind of talk to our patients about to try to avoid other things that could negatively affect their bone. We talk about adequate nutrition. So calcium intake is extremely important, and what we talk about is adequate calcium intake. So similar to what Bob Pignolo mentioned about adequate calcium intake to prevent kidney stones, we also want you to have adequate calcium intake for your bone health. We usually recommend about 1,000 milligrams of calcium a day, and that usually can be accomplished by having about 3 servings of food items that are rich in calcium, like milk, cheese, yogurt. So if you can see in this figure and below, the circular figure, it lists some of the food items and how much calcium is in them. Calcium supplementation can be used, but we usually don't recommend more than 500 to 600 milligrams from calcium supplements because of the concern with increased risk of kidney stones. In patients who are taking famotidine or omeprazole, medications that suppress the amount of acid in the stomach, calcium citrate is better absorbed than calcium carbonate, so we do recommend calcium citrate. We do recommend adequate amounts of vitamin D intake, again, not excessive, but about 800 to 1,000 units of vitamin D3 could be enough. We do sometimes check 25-hydroxyvitamin D levels and replete if that remains low. And of course, fall prevention is something that we always discuss with all of our patients to prevent bone injury, but also overall injury. Next slide. So what about pharmacological options? We in the osteoporosis world have several medications that are approved for osteoporosis treatment and have been shown to be effective at decreasing risk of fractures in the spine and in the hip and in other locations. What I've listed here are potential medications that can be considered in FOP. The first one is bisphosphonates. These are the most widely used medications for osteoporosis treatment. You might have heard of medications like Fosamax or Actonel or Boniva. These are some of the medications that can be given in a pill form, but we also have bisphosphonates that can be given intravenously. What we have used mostly in FOP, people living with FOP, has been the intravenous forms, so either zoledronic acid or IV pamidronate. These two medications, I will talk about them in more detail tomorrow during my talk about off-label use of medications in FOP. But we have used these medications in people living with FOP who are having relentless flare-ups or have an ongoing flare-up that has required a significant amount of prednisone exposure or glucocorticoid exposure. And so we have used those medications in the hope to try to break that flare-up cycle, but more so to really protect the normal bone from all the negative effects of the prednisone that they were on because of that flare-up. We are careful and we don't use, we try to correct any low calcium or low vitamin D before administering these medications because they can cause hypocalcemia or a drop in the calcium level. We try to avoid using these medications in patients with chronic kidney insufficiency or kidney problems because it can worsen the kidney function. And we also need to make sure that any active ongoing dental issues are taken care of before we administer those medications because they could interfere with the bone healing after invasive dental work. The second medication is denosumab. The brand name is Prolia, and that medication is given subcutaneously every 6 months, and that's approved for treatment of osteoporosis in the general population. I am not aware of this medication being used in people living with FOP. It wouldn't be my preferred drug. It can increase risk of infections, and it can also cause the calcium to drop. But my major concern with this medication is that although it is highly effective while the patient is on this medication, there's significant rebound bone loss and potential for increased risk of compression fractures if this medication is stopped or missed. And so that really would not be my preferred first-line treatment. And in our young patients who either have low testosterone or low estrogen, we could consider hormonal replacement therapy. With the estrogen especially, we do worry about increased risk of breast cancer and then also stroke, myocardial infarction, or blood clots as well. But we have, a lot of younger, FOP patients, females as well, who have amenorrhea or haven't gotten their periods or are taking oral contraceptives because they have very heavy periods. And so we have experience with the use of oral contraceptives and estrogen replacement, and that has been relatively well tolerated and safe. So that could be an option. So with that, I think that concludes my talk. I think I'm the last speaker, so hopefully we'll have enough time to answer all your questions. And thank you for your attention.
So if I could get Doctors Pignolo, Hidalgo-Bravo, and Shao to join me on stage. We are going to have some time for Q&A from the audience, but while they're coming up, we are going to be welcoming one more speaker to the virtual stage, and that is Dr. Fred Kaplan. So Dr. Kaplan is sort of the man who needs no introduction, but because we have so many new families to the FOP community here today, I did want to say that Dr. Kaplan works with Dr. Mukaddam at the University of Pennsylvania. He is the co-director of the Center for Research in FOP and Related Disorders and is recognized as the world's leading expert on genetic disorders of heterotopic ossification and skeletal metamorphosis. So, Dr. Kaplan, would you like to start us off by just saying hello to everyone since you didn't have a chance to speak.
I will. I want to. Thank you so much. Thank you. Thank you, everybody, for being there. I'm sorry I can't be there, couldn't be there this year. I hope to be present next year. For personal and health reasons, I couldn't be there this year. But hopefully I'll be there next year. I want to thank Ed. I want to thank all the speakers for beautiful presentations this morning. And I want to thank Ed for stepping in and doing a fabulous job and bring everybody up to date on the highlights of clinical basic research and the publications that were that we saw this year. So thank you all. Thank you, Ed, and I hope to be with you next year again. Thank you.
And I'm sure you all have questions, but Dr. Kaplan, I wanted to start with one for you. The question is, what is the CAGES score? How does it work, and why is it used? And I think this is a really important question because as we go into our Ask a Doctor meetings later today, for newer families, they may hear this term come up. And so if you could just help familiarize them with that.
Absolutely, absolutely. Thank you, Hope. Thank you very much. Dr. Pignolo, Dr. Mukaddam, and I developed the CAGES score out of desperation, out of necessity, really. Many years ago, during the first phase of the palovarotene project, and actually during the natural history study, where range of motion was recorded, we got 6-7 pages, beautiful, beautiful reports from the physical therapists of all the different ranges of motions of the different joints. And we said, how the heck can we put this into a, into a framework for assessing whether the patient is actually getting better or worse? We need something very quick. We need something that we can assess very quickly, sort of like the APGAR score. I don't know if everybody's familiar with that. When a child is born, there is a immediate 15-second or 30-second assessment of the child. And we said we need some sense, some way to assess physical mobility very quickly, whether we're in Philadelphia or San Francisco or Mexico City or Rochester, Minnesota, or the wilds of Africa. We absolutely need something that we can do very, very quickly in a clinical setting. And we came up with a system that assesses how the neck moves, how the chest moves, whether it expands properly, whether someone can flex forward, and whether the shoulder is mobile, whether the elbow is mobile, whether the wrist is mobile, and also the hip, the knee, and the ankle. Clearly, the fingers are important, and the toes are important, et cetera. There's many other joints to measure, but there are 6 joints in the upper limbs, 6 joints in the lower limbs, and 3 areas of the axial skeleton that we assess, basically 30 areas several areas in the body, and we assign a 0, a 1, or a 2. A 0 means there is no effect, the area is not, the joint is not affected. 1 is it's 10% to 90% affected, and 2 is more than 90%. So it's a very rough measurement, and it gives us a very clear idea of whether of how mobile the individual is. It's a very quick assessment. It can be done anywhere in the world. You don't need any equipment to do it, and it can be done in less than a minute. And amazingly, it correlates with degree of disability and degree of bone formation and heterotopic ossification. It's a very, very good measurement of assessment of joint function. It does not say whether the joint is affected by heterotopic bone or whether it's affected by by joint non-heterotopic ossification. For example, we all know the toe is malformed in FOP, but and the joint, the interphalangeal joint where the in the toe does not develop properly. But there's other small joints in the body that don't develop properly as well. So in the back of the neck, the facet joints of the cervical spine, where the ribs join the spine, they can undergo early degeneration, and it's not due to heterotopic bone. It's due to the joints not forming properly, and so too much of a bone forming signal leads to too little of a joint forming signal, and some of the joints are more susceptible than others. So the Kaja score doesn't really assess whether the immobility is due to heterotopic bone or due to joint malformation, but it's a very global and very rapid assessment of mobility and FOP, and it assesses, again, the neck, the jaw, the chest, the shoulders, the elbow, and the wrist on both sides, and it is a very, very accurate indication of immobility in FOP.
Thank you for helping prepare our families in that way, Dr. Kaplan. We'll take questions from the audience. We've got some mic runners out, if anyone has anything they want to start us off with. I see your hand, Lori.
As someone that has FOP, and I was lucky to have a spinal fusion in 1976, and I know the rarity of it, but my concern is the spine. A lot of young kids have scoliosis at a younger and younger age. Knowing that you can't do surgery, is it possible for a Milwaukee brace or a back brace? Because it would relieve some of the pressure in the back. But my concern is, even for me, I had an 87-degree curve, less than 50% lung capacity. I don't want that to happen to anyone in this room. I want, for what the researchers are doing, I want people to be here to have a life of their own. I'll be 62 next week, and I'm glad to be here. But I want others to be able to have a full life. And it's just more than the medicine. It's the adaptive tools that you need and the devices to make you independent.
Thank you, Jessica. Thank you for that question. Back in 1993, we published a paper, 94, published a paper. Pinak Shah was the chief author on that. And we looked at all the patients up until that time that had scoliosis and had surgery or a brace. And that paper is published. It's in the Journal of Bone and Joint Surgery. And it is the basis for our ongoing concern for scoliosis surgery. Many of the patients were not improved, and there was a lot of complications from scoliosis surgery, especially including the anesthesia, the anesthetic, the general anesthesia that's necessary for scoliosis surgery. Fast forward, scoliosis surgery has evolved over the past 30 years, and there are a few patients who have had very quiet episodes of FOP, where FOP is quiet prior to puberty, where the scoliosis is increasing at an alarming rate. And we have had 2 patients operated, within the last several years, and they've done very well. However, the anesthesia was risky, and there were large post-operative problems in both patients. Both are very happy with their outcomes. So the jury is out still on whether scoliosis surgery can be done. It's extremely risky in FOP patients, and I want to emphasize that. We did look at, in the 1993 paper, at the possibility of a Milwaukee brace. Unfortunately, braces were not tolerated well in FOP patients. So because of the immobility and because of pressure sores and because of other things. So we are, again, as Dr. Shao said in his beautiful presentation this morning, it's a balance between benefit and risk. And will a patient benefit from surgery, or is there tremendous risk? And like Dr. Shao said, you have to ask the question, what would you do if the patient didn't have FOP? And if they do have FOP, how can you make it as safe as possible? Or if it isn't safe, don't do it.
Thank you, Dr. Kaplan. And Lori, I want to get to your question. Before we go to that, though, I had a follow-up question that came in from online that I wanted to ask Dr. Pignolo, because you did, sort of do's and don'ts. And the question is asking about really preparing for an emergency. So they're wanting to know who they should contact in the case of emergency, and what advice would you give families to have a plan to be ready for a medical emergency?
Yeah, that's a great question. So I think many of you are aware that the IFOPA has created emergency cards, and on those cards are the names of, at least in the U.S., the names of contacts of FOP experts, and so you should always carry your IFOPA emergency card. I believe this kind of card is duplicated in other countries. I think it's a great idea. So I've been contacted by emergency room physicians, by hospitalists, and I think we're all willing to give them the answers that treating physicians, emergency physicians want. So I think that's number one. But other things in terms of preparedness, I mentioned in my talk to the pill in the pocket. Keep a supply of steroids with you all the time. You never know when a trauma is going to occur. You never know where you're going to be. Also, I think there are the other important point is to be able to recognize when something is an emergency for someone with FOP. I mentioned the submandibular flare-ups. That's a medical emergency. Certainly, traumatic falls where you hit your head, that's an emergency. So being able to recognize when an emergency happens, being able to have your IFOPA or other emergency card, and keeping a supply of steroids on hand. I think those are probably the three most important things.
Those are three great tips to remember. Oh, Dr.
Yep, sorry, and I want to add one other item, is the ICC FOP website has the treatment guidelines. It's very comprehensive. It covers many of the different situations. It's often not as usable in an emergency setting, but there is an executive summary, which we would strongly recommend that you print out and give to like your school nurse or your work nurse or your clinician, so that they have that information as a really rapid reference. And so having that plus the emergency card is really valuable. And then on both the IFOPA website and the ICC FOP website, there's a list of curated videos. These are short videos. Some of them are longer. Some of them are CME related, as Michelle and the group was talking about last night. But a lot of these can be used as really quick trainings for physicians, just to get them into the game so that they understand what can and cannot be done for patients with FOP.
That's a great. That's a great point, Ed. There's also in the ICC management guidelines a cheat sheet for first responders, so emergency physicians and first responders, which is even a little shorter than the executive summary. So that is also in there. I think it's maybe 2 pages long at most. So all good resources.
Yeah, and I just want to add to that, we're in the process, the ICC is in the process of updating the clinical guidelines, and hopefully they'll be posted on the ICC website and the IFOPA website in the first half of 2024. So the ICC has been in the process for the past year of updating these guidelines, and they're major new sections. And so keep your eye out in the first half of 2024 for those.
Thank you, Dr. Kaplan. Now over to you, Lori.
I just had a question about submandibular flare-ups. So you go to seek medical attention. What can you really tell them? We had a situation where Erin ended up at the emergency room because she couldn't swallow. The doctors didn't really know what to do. So how do you treat that as an emergency situation?
Yeah, that's a very good question. We published a paper on this many years ago because we were alarmed at seeing a patient with a submandibular flare-up. Basically, you couldn't distinguish between the chin and the chest. There was such massive swelling. And that was the first time we used IV steroids, intravenous steroids, to bring the swelling down. Usually the swelling can be brought down by oral steroids and quite rapidly and quite successfully. I don't think the pathology, looking under the microscope, I don't think the flare-ups in the submandibular region are any different than flare-ups anywhere else in the body in terms of the cells that are affected, in terms of the process that's going on. I just think it's a location. It's a very, very dangerous location because it involves swallowing and breathing and eating and so on and so forth and speaking. I just want to say that not all submandibular flare-ups require a massive approach to steroids. They do not. Many of them they should all be treated, but their hospitalization is not required for most. But I would certainly, if somebody's having trouble swallowing, they probably should be admitted to the hospital and give intravenous steroids and then move the patient to oral steroids later on. But that's rare that a patient will have trouble breathing or swallowing. What I commonly see is the swellings of the neck and the swellings in the submandibular region, and they involve the muscles that move the tongue, not the intrinsic muscles of the tongue, but the muscles that actually move the tongue. They're on the floor of the mouth, and they can get affected, and that can affect speech and swallowing and breathing, etc. So if those are involved, I would use if there is a submandibular flare-up, which usually does not affect jaw mobility, but can affect these other things. I would use the steroids very often, like Dr. Pignolo said, have the pill in the pocket approach. It's like having a fire extinguisher in your kitchen. You use a fire extinguisher and then you call the fire department. Hopefully you won't need it, but you'll have it available for flare-ups, and flare-ups in the submandibular region are among those that are most concerning to us. One of the things I've seen in submandibular flare-ups is doctors often think it's the mumps, or they think it's the parotid glands, and they'll palpate, they'll touch those areas, and they'll actually make the swelling worse. So keep your hands off. Tell the doctors to keep their hands off. Give a lot of steroids, and then call us if there's any, if there's some issues, and we'll guide you through that.
Thank you, Dr. Kaplan. So we are over time. If there's one more question from the audience here, we can take it before we wrap up. Everyone is good in here. Oh, we got one. Okay.
Okay, so I was just curious as to whether or not you all have noticed an increase in FOP patients going into puberty early, and if they do, how do we regulate those hormones?
I can take that. So that is a great question. I think everybody gets concerned for puberty for lots of reasons. and that is an area of active study. So you will probably hear about a puberty and height study that will be coming out between our team at UCSF, Mona, and then also from the UK with Dr. Keane. So that is an area that we don't have a lot of information on yet.
Mona, did you want to add anything?
Yeah, I just wanted to add one thing. I don't know that we've necessarily seen early puberty in FOP patients per se, but I think as a general population, that's definitely been a trend that's been seen in the general population. And so there's actually been a lot of papers on why is it that people are going into earlier puberty. Is it some of the diet? Is it our diet? Is it some of the plastic that's being, that is endocrine disruptors or other, environmental factors that is causing this, early puberty? I think during COVID as well, with the weight gain that happened in children, that's been noted globally. So this is not related to FOP, but I think globally we've been seeing, more precautious puberty.
Great, thank you. And